In this video you will see modern classification of AV block from Josephson's clinical cardiac electrophysiology book, his bundle electrogram features, situation when first-degree AV block needs a pacemaker, characteristic of second-degree AV block, also we describes typical and atypical Wenckebach periodicity, ECG criteria of second-degree AV block type Mobitz II and risk of progression to more severe decreases, differences of AV block with 2:1 conduction and high-degree AV block, pathophysiology of Stokes-Adams syndrome, causes of complete AV block and ventriculophasic arrhythmia development, features of Frederick syndrome and Lyme Carditis. All degree AV blocks will followed by real ECG example with explanation and European cardiology guideline recommendations. You can use the time codes for checking the most relevant information for you. AV block is impaired conduction between the atria and ventricles. In aspect of AV block management, we need to know degree of AV block, anatomic site of AV block, and prognosis to progression. The first degree AV block is characterized by prolonged AV conduction, but the truth is that is not a block in nature, because the absence of QRS drop. Second degree AV blocks are characterized by intermittent conduction with QRS dropping. 2:1 conduction is characterized by dropping every second QRS. High degree AV block is characterized by dropping 2 or more consecutive QRS. Third degree is defined as absence of conduction between atria and ventricles. Let's quickly remind how the ECG waves and segments are formed. Normally, impulse leaves the sinus node and depolarizes the atria first. Atria depolarization we see as a P wave. After this, impulse goes through the AV node, his bundle, and his bundle branches. Conduction through the AV node, his bundle, and bundle branches are represented by PQ interval, or in case of Q wave absence, PR interval. Depolarization of the ventricles is represented as QRS complex. T wave is ventricular repolarization. There are 4 sites of origins where AV blocks can occur: at atria level, AV nodal level, at the level of his bundle, and lower than his bundle. Both atria and AV node level form proximal AV blocks that is usually not related to structural changes and have benign prognosis. Intrahis and infrahis level form distal AV block and usually caused by structural changes. As you see that atrial level of block is represented only by first degree AV block. AV nodal block is virtually never can be represented by second degree AV block type 2. However, second degree AV block type 1 is uncommon for intra and infrahis level of block. For understanding the basic electrophysiology of AV blocks, we need to check the His bundle electrogram. His bundle electrogram is recorded if we put the electrodes inside the heart, in the place where his bundle is located. It is consist of spike A, potential of inferior part of right atrium, spike H, his bundle potential, spike V, ventricular potential. According to this, we can measure the following intervals: PA interval, from the onset of surface ECG P wave to spike A on electrogram. It describes the conduction time from the sinus node to lower part of right atrium. Normally it is in range from 15 to 50 milliseconds. AH interval describes conduction time from the low right atrium through the AV node to the His bundle. Thus, the AH interval is the best and only an approximation of AV nodal conduction time. The normal range is from 50 to 130 milliseconds. Spike H represents conduction time through the His bundle. Normally it should be less than 25 milliseconds. The HV interval represents conduction time from the proximal His bundle to the ventricular myocardium. Reported normal values in adults range from 25 to 55 milliseconds. As you see, that AH interval as a maximal possible interval on His bundle electrogram mostly forms a PR interval on surface ECG. First-degree AV block is defined as prolongation of PR interval more than 200 milliseconds in adults. AV node is the most common site of first-degree AV block. On his bundle electrogram, we find AH interval prolongation. On ECG, we find PR prolongation with normal contour and duration of QRS. In case of intra-His localization of AV block, on electrogram we find the split of H spike to two waves, H1 and H2, and duration more than 20 milliseconds. On ECG, QRS is usually unchanged or slightly wider than normal sinus. In case of infra-His AV block localization, usually 2 of 3 bundle branches are persistently blocked, and first-degree AV block exists in the last free bundle branch. On his electrogram, we find HV interval prolongation, and on ECG, PR prolongation with bundle branch block QRS morphology. Let's go to real ECG example. This is 24-hour ECG episode. Paper speed is 50 mm per second. PR interval is equal 1 large boxes and 8 small boxes or 260 milliseconds. That is more than 200 milliseconds. QRS duration is equal 4 small boxes or 80 milliseconds. So the level of AV block in this case is located in the AV node. Another ECG example. Paper speed is 50 mm per second. As you see, PR interval is equal 2 large boxes and 3 small boxes, or 260 milliseconds. Also we see the wide QRS with left bundle branch block morphology. So the prolonged AV conduction occurs in right bundle branch. According to the European Society of Cardiology guideline, in case of first-degree AV block, prognosis is good and progression to the high-degree AV block is uncommon. As a result, treatment is not required. So, first-degree AV block is benign and asymptomatic. But in case of marked PR interval prolongation greater than or equal to 300 milliseconds, particularly when it persists or is prolonged during exercise, it can lead to symptoms similar to pacemaker syndrome and can be improved by pacing, so in this case pacemaker implantation can be considered. If you need to check more information about symptoms development during the first-degree AV block, we have another video about this, link will be in description. If you like the content, press like and subscribe buttons. Second-degree AV block means that some of P waves is not conducted to the ventricles, so QRS complex is dropped. Second-degree AV block type 1 or Mobitz I is characterized by progressive PR prolongation. The vast majority of second-degree AV block type 1 is located at the AV nodal level. The ECG criteria of second-degree AV block type 1 are follow: progressive lengthening of PR interval until the beat is dropped, variable RR interval with a pattern, regularly irregular, pause is less than 2 previous RR interval, PR interval after the pause is less than PR interval before the pause. Now let's find all of these criteria on schematic ECG. Firstly, we see the progressive lengthening of PR interval until the QRS is dropped. Now let's check the regularity by measuring the RR interval. The first RR interval is equal 8 large boxes and 2 small boxes, or 840 milliseconds. The next one is equal 780 milliseconds. So the RR interval becomes progressively shorter before the pause. Unlike PR interval, that becomes longer. Pause due to QRS drop is equal 1200 milliseconds. The maximal increment of PR interval occurs in the second complex, and it is equal 140 milliseconds. Maximal increment in second complex forms this regularly irregular pattern when RR interval becomes shorter before the pause. This periodicity is called typical Wenckebach periodicity. More often, Wenckebach periodicity is atypical, and it is characterized by maximal per-interval increment in another than second complex, so RR pattern also changed, not becomes shorter before the pause. Both typical and atypical Wenckebach periodicity forms a regularly irregular pattern. Pause is less than 2 previous RR interval. PR after the pause always is less than PR before the pause. When the block is located in AV node, on his bundle electrogram we see the progressive AH interval prolongation until the HV spikes drop with further restoration of conduction. QRS on ECG is narrow. When the block is located inside his bundle, we see splitting of H spike to two different spikes, H1 and H2, with progressive lengthening of distance between them until the H2 and V are dropped. QRS in this case is narrow too. When the block is located in one of his branches, on ECG we see wide QRS due to permanent block of another branches, and on his electrogram progressive lengthening of HV interval until the V spike is dropped. Let's go to real ECG examples. We see the progressive PR interval lengthening until the QRS dropping, so the first criteria is present. Firstly, RR interval becomes shorter and after remains the same, with max increment in second complex. But further, we don't see RR interval shortening, that means atypical Wenckebach periodicity. That indicates regularly irregular pattern, so second criteria is present. Pause is less than 2 previous RR interval. The third criteria is also present. PR interval after the pause is smaller than before the pause. So the last ECG criteria is present. The QRS complex is equal 80 ms. That suggests the AV nodal level of block. Let's also describe conduction. For this, let's calculate the total number of P waves and number of P waves that were conducted to the ventricles. There are 5 P waves. From these 5 P waves, only 4 P waves were conducted to the ventricles, so the conclusion is second degree AV block type 1 with atypical Wenckebach periodicity with 5 to 4 conduction at the AV nodal level. According to the guidelines, we need to check the risk of progression to higher degrees. Therefore, supranodal and nodal block has benign course with low risk of progression. Infranodal block, that is rare in this form of block, carries high risk of progression to complete AV block, syncope and sudden death, and warrants pacing in the absence of symptoms. So pacing should be considered in this case. Second degree AV block type 2 or Mobitz II is represented by sudden conduction failure. This type of AV block can occur at intrahis and infrahis level and virtually never at the level of AV node and atrium. The ECG criteria are follows: dropped QRS that are not preceded by change in PR interval. Pause duration is equal to RR interval or slightly shorter. Look at the ECG scheme. We see the QRS drop. PR interval is constant before and after the QRS drop and equal 160 milliseconds. Now let's check the pause duration. RR interval before the block is equal 700 milliseconds. The pause is equal 1400 milliseconds. So pause is equal to 2 RR interval. In case of intra-His AV block localization, in His bundle electrogram, we see the split of H spike to two different spikes, H1 and H2, with further rapid H2 and V spikes dropping. When the level of AV block is located in the one of his branches, another two should be totally blocked by concomitant bundle branch block. As a result, on ECG we see white QRS with bundle branch block morphology and rapid QRS drop-in. On his electrogram we find the rapid drop of V wave. This type of AV block may progress to complete AV block, and it usually indicates a structural abnormality such as ischemia, fibrosis, or sclerosis. Now let's go to real ECG example. Paper speed is 25 mm per second. We see the P wave without further QRS, so this is QRS drop. PR interval before and after the drop is constant, so first criteria is present. Pause is almost equal to two previous RR interval, so this is second degree AV block type Mobitz II. After the first QRS drop, we see the second, the third and fourth QRS drops. It means that every second QRS complex is dropped, which is the criteria for second degree AV block with conduction 2 to 1. QRS complex is 80 millisecond, so the most probably we see intra-His level of block. Second degree AV block with conduction 2 to 1. The ECG criteria is P wave with constant rate, where every second QRS complex is dropped. Block can be at the level of AV node. On ECG we see P waves with constant rate. PP interval is equal to each other and every second QRS complex is dropped. So for 2 P wave we have only one QRS complex as a result of conduction 2 to 1. PR interval is in normal range and is equal 180 millisecond. On his electrogram, in case of AV nodal level of block, we see the drop of H and V spikes, and noro QRS on ECG. When the block is located at the level of his bundle, we see almost the same picture, but with some differences. In fact, a normal PR, particularly less than 160 millisecond during 2 to 1 AV block, is virtually diagnostic of intra-His block if the QRS is noro. On electrogram, we again see splitting of H spike to two different spikes, H1 and H2, with drop of H2 and V spikes. In case of infra-His AV block localization, we see the same picture but with white QRS complexes due to concomitant bundle branch block. Electrogram demonstrates the V spikes dropping. Let's go to real ECG example. Paper speed is 50 mm per second. P wave without QRS indicates QRS dropping. Before the drop-in, we see the progressive PR interval prolongation. PR after the pause is less than before the pause. All of above indicates second degree AV block type Mobitz I. After the first drop, we see that every second QRS complex is dropped. P wave has constant rate 64-66, so the criteria of 2 to 1 conduction is present. As a result, we have second degree AV block type Mobitz I with progression to 2 to 1 conduction. If we see Mobitz I, we know that the injury is located in the AV node. Noro QRS and huge prolongation of PR confirm that. Now you can see the table for distinguishing the site of 2 to 1 AV block. The next step is advanced or high grade or high degree AV block. The ECG criteria is the greater than or equal to 2 consecutive P waves at a constant physiological rate that do not conduct to the ventricles with avoidance of some AV conduction. According to this, conduction should be at least 3 to 1. Let's see the ECG scheme. Here we see the 3 consecutive QRS drops. As a result, we have 4 P wave and only 1 QRS complex. Therefore, conduction in this part is 4 to 1. in the first complex and in the last PQRST, we find the evidence of normal conduction. Consecutive QRS drops lead to ventricular asystole, that means decreasing of both stroke volume and heart rate. Stroke volume and heart rate form cardiac output, that is also decreased. Cardiac output together with total peripheral resistance form mean arterial pressure, that is also decreased. Decreasing of mean arterial pressure lead to brain hypoperfusion, that in its turn lead to syncope. Syncope that occurs due to conduction disorder calls Stokes-ADAMS syndrome. Stokes-ADAMS syndrome can occur at any block that lead to low heart rate or long asystole period. Should be noted that escaped rhythms from the latent pacemakers can arise inside the pulse. Now let's go to real ECG example. Paper speed is 25 mm per second. At the beginning we see the AV block with conduction 2:1. After this we see the progression of 2:1 conduction to 3:1. So criteria of high degree AV block is present. Both long PR interval and noro-QRS suggest AV nodal level of block. Should be noted, high-grade AV block transforms to the complete AV block frequently. The next step is third degree or complete AV block, that is characterized by no conduction between atria and ventricles. It can occur at all levels except of atrium. In case of complete AV block, no atria impulses are conducted to the ventricles. According to this, atria and ventricles are controlled by different pacemakers. Condition when atria and ventricles are controlled by different pacemakers called complete AV dissociation. Therefore, complete AV block is one of possible causes of complete AV dissociation. By the way, we have another video about AV dissociation, link will be in description. In case of complete AV block, atrial rate is always greater than ventricular. Let's start from AV nodal level. Usually, complete AV block at AV nodal level occurs due to congenital problem, acute inferior myocardial infarction, and beta blockers, calcium channel blockers, or digoxin intoxication. So in this case, atria are paced by sinus node, that is indicated on ECG by regular sinus P wave. In our case, rate of P waves is 85. Ventricles in its turn are paced by pacemaker that is located lower than level of block. In our case is a His bundle, as the His bundle pacing rate is usually higher than 40 beats per minute and characterized by noro-QRS. QRS complexes in this case randomly interrupt PP intervals or P waves. As you see, atrial rate is much higher than ventricular. On His bundle electrogram, we see that A spike is not followed by His deflection, but each ventricular spike is preceded by His deflection. QRS complex in case of His bundle patients is noro. When the block occurs at the level of His bundle, ventricle can be stimulated from the lower part of His bundle before the trifurcation of branches. In this case, we also see the noro-QRS, but ventricular rate is lower. On electrogram, we see a spike that is connected to H1 spike, and every V spike is connected to H2 spike that indicates H spike splitting in case of His bundle level of AV block. Infra-His level of block is caused by acquired reasons. In this case, ventricles are paced by pacemaker that is located in one of His bundle branches. According to this, ventricular depolarization goes in different than normal way. So in ECG we see the wide QRS, usually with pace that lower than 40 beats per minute. On electrogram, spikes A are connected to H spikes, thus V spikes are not. Sometimes you can see that PP interval that contains the QRS complex is shorter than PP interval that doesn't have a QRS inside. This phenomenon called ventriculophasic arrhythmia. Ventriculophasic arrhythmia is a phenomenon commonly seen in patients with complete AV block. The usual observation is that the PP interval containing the QRS complex are shorter in duration than the PP intervals without an intervening QRS complex. This phenomenon was first observed by Erlanger. There are few possible mechanisms that can explain ventriculophasic arrhythmia. Changes in baroreceptor output resulting from the stroke volume caused by ventricular contraction. Stretch of the right atrium and sinus node with ventricular contraction that augment the sinus node automaticity, and alteration of sinus rate due to changes in sinus node blood supply in response to ventricular contraction. Sometimes on ECG we see the combination of sawtooth waves that indicates atrial flutter and regular slow ventricular rate that indicates the latent pacemaker activation due to complete heart block. Or we see the combination of fibrillation waves and slow regular ventricular rate. Combination of complete heart block and atrial fibrillation or atrial flutter called Frederick syndrome. We have another video about this, link will be in description. Now let's go to real ECG example. Paper speed is 25 mm per second. Heart rate is less than 40 beats per minute. You can see that P waves interrupts QRS complex in random manner. That means no P waves conducts to the ventricle. P wave rate is near to 90 beats per minute. Therefore, atrial rate is greater than ventricular. In the middle of the street, we see the shorter PP interval that includes QRS and equals 660 milliseconds. After this, we see the relatively longer PP interval without QRS complex inside. That is equal 720 milliseconds. This is example of ventriculophasic arrhythmia. Also we find the negative P wave in second standard lead that indicates the lower atria rhythm. When the lower atria rhythm is greater than 60 beats per minute, we call it accelerated atrial rhythm. QRS complex is narrow. As a result, we have complete AV block, level of injury possibly at the his bundle due to the narrow QRS and low heart rate with accelerated atrial rhythm. Finally, let's check the current guidelines for second degree AV block type Mobitz II, 2-1, high degree and complete AV block. In the absence of reversible cause due to the risk of occurrence of severe symptoms and or possible progression towards to more severe or complete AV block, patient should receive a pacemaker even in the absence of symptoms. In asymptomatic patients in whom 2-1 AV block is found incidentally, the decision for implantation should be made on case-by-case basis, including distinction between nodal and infranodal AV block. This distinction may be based on observations such as PR or PP interval prolongation before AV block, the effect of exercise on AV conduction, and an electrophysiological study. Pacing is also indicated for patients with Frederick syndrome. In this case, ventricular pacing is more suitable. Another important aspect of AV block is Lyme disease-induced Lyme Carditis. Lyme disease is tick-borne bacterial infection caused by Borrelia burgdorferi that is transmitted by bite of Ixodes tick. Occurrence of Lyme Carditis varies from 4 to 10% of all patients with Lyme disease and usually manifests in 1-2 months after contamination. AV blocks develop in 90% of patients with Lyme Carditis and mostly are represented by third-degree AV block. But this AV block is transient and usually resolves with antibiotic therapy. According to this, pacemaker implantation is not necessary. If you like the content, press like and subscribe buttons. Have a good day.